instalment of Research Matters in our 2024 speaker series, and this one focuses on women's health. Before we begin, I'd like to acknowledge the Muinina people, the traditional custodians of this land, and pay respects to their elders past and present. I'm John Stubley. I'm the interim CEO of the Royal Hobart Hospital Research Foundation, and our mission is to fund innovative medical research that improves the health and wellbeing of Tasmanians. We're thrilled to host this event in partnership with St Luke's, a fantastic venue for learning and exploring critical health issues, especially those related to women's health. I'm also pleased to introduce our facilitator for the evening, Kylie Baxter from ABC Radio. Thank you, Kylie.
Hello everyone. Lovely to have you here. Thanks for taking the time after the wild storms and everything else that's been happening to come in this evening. Thank you so much, John, as well for your introduction. So tonight, or this evening, we are delving into women's health research, an area that I'm really passionate about. I love talking about it on the ABC and have had so many different guests. Jane has been a guest on the ABC in the past. And Michelle, my next guest, who I'll introduce formally in a moment. But yeah, if you are ever wanting to have your view on anything on the ABC or suggest guests, we always love to hear people's ideas. But tonight, this is a chance to look at some unprecedented research, looking at care, the way things are changing, and we'll explore the latest advancements in women's health and also how they impact the health of Tasmanian women. You might actually be impacted by a health condition or know somebody that is, and this could be actually very relevant to you personally. So I want to introduce you to our very distinguished panellists who've done a huge amount of research. Associate Professor Jane Alty here, directly to my left, is a neurology clinician, a researcher, an educator. One of her aims is to transform the health of older adults by detecting the earliest stages of degenerative brain disorders and also to improve health literacy and clinical care. So the focus is on both Alzheimer's and also Parkinson's, and I'm sure we'll get some wonderful insights into early detection, but hopefully also things that we can do that will prevent early onset. And my other esteemed guest here is Dr. Michelle Kilpatrick, and she's a public health researcher with a background in psychology. Michelle's work addresses the barriers and also the enablers of health behaviours and supports positive changes in various populations. So the big focus, this is really interesting, I find this fascinating myself, well beyond this phase myself, but health during preconception, pregnancy, and also the post-birth period for women and their babies, because this is something that I feel like it's not talked about that much generally in the population, definitely not in classes that you do as a mum when you're young, and not that much on the radio either. So if everybody's happy to get underway, we're going to answer lots of questions. This is just like a chit chat, so you guys will get a chance to also hopefully ask questions if you feel like you'd like to. I'm going to start with you, Jane. I'd love you to share any recent advancements in women's health, health research, that and how they might have had a significant impact on health outcomes. And remember, that's very directional, that microphone. Let us know, do a little hand wave if you can't hear any of our microphones.
Is that okay? Yeah. I think that's a really great question. And when I was at medical school or when I was a junior doctor, we weren't really told about sort of sex differences between common conditions. And I think it's really relatively recently that we've started to think about, okay, perhaps, I'm speaking as a neurologist, so talking about the brain, but that men and women's brains may be different. And that seems so obvious to us now, but if you look back through a lot of research, you'll see predominantly men have been in those clinical trials, and then we've just assumed that the findings from those clinical trials would apply to women too, and then surprise, surprise, it doesn't always follow. So now I think a big breakthrough is that we're told to have really equality in these clinical trials when new drugs are being tested and so on. And as a researcher, when I apply for a grant, there's specific sections saying how many women are you going to have in your trial, because traditionally women have been really underrepresented in research. And I think in terms of outcomes, with my clinician hat on, because I work at the Royal Hobart Hospital as well as at the university, for example, with Parkinson's, we know women with Parkinson's are more likely to develop certain side effects, something called dyskinesia, where they move and sort of wriggle, which is a side effect of one of the medications. So a really common thing, which is really straightforward, is we give a slightly lower dose, which is so obvious, but that was never in our guidelines. It was just give everybody the same dose.
Oh, very interesting. And yeah, I'd be fascinated to hear a little bit more about that. But I'm going to come to you with a question now, Michelle. I'd like to know, and I think everybody would be very interested to know, the current challenges in addressing women's health through medical research, and where the most significant gaps are, in your opinion.
Certainly. So my perspective is going to be very, very different to Jane's. As a public health researcher who's recently moved into mental health research, service research as well, I speak not as a clinician or with a medicine background, but with more of the pragmatic, how can we affect change in the health system kind of approach. So I've been very much focused around translational research, that implementation research, it's a buzz thing, which is really the nuts and bolts of how we can affect sustainable change in the health systems that we work in. And the project that I will be speaking about today will focus a bit on that translation. But that was working with maternity services at the Royal and looking to see how we could support them to support women around health behaviour, because we know it's a really critical point. There are some significant challenges in working with pregnant women, as it turns out, in a research capacity. So while it's incredibly important to focus on women's health in pregnancy, because it can have really important outcomes for mums and their babies, some of those challenges can be around, I guess, the ethics of working with, there we go.
Yeah.
Around the ethics of working with pregnant women in a research capacity.
What do you mean by that, the ethics? Can anybody, I feel like you can't hear me, but there we go. When you say what sort of ethical issues could arise?
Well, when you're inviting people to be research participants, it's very important that there are no perceived power imbalances, I suppose, and in inviting women to be part of research, they don't, in a clinical capacity, they're there to be cared for throughout their pregnancies. We really don't want them to feel that their care will be in any way jeopardised if they agree or not in pregnancy. So we really have to take that seriously. And there are other challenges as well around diversity. We know that there are lots of health challenges for Tasmanians in general, but we know for women in Tasmania, people from different cultural backgrounds, lower socioeconomic areas, who are harder to engage in research, and this is within Tasmania and nationally and globally. So we can end up having quite, we don't end up knowing as much as we should about these populations, and therefore we can't help them in the way that we would like to.
Yeah, it makes perfect sense. Jane, coming back to you, how is research in women's health being translated into practical solutions? Because everybody loves to see research being done, but obviously you want to see outcomes as a result of that search. So what does it mean for healthcare providers and for patients? What are they getting out of this?
Perhaps overlapping with some of your work, I think there's been a big change in healthcare from just treating conditions to actually trying to prevent conditions. And this is quite a novel concept in degenerative brain disorders. So many people think it's just bad luck if you develop dementia, or it's just bad luck if you develop Parkinson's. And this is quite cutting edge, actually, that we're now realising there is a degree of luck, and of course we can't change our genetics. But actually, for example, with dementia, almost half of dementias can be prevented. And how can you prevent them? It's the sort of things that's good for your heart is good for your head. So, doing more exercise, drinking less alcohol, not smoking, and so on. So this now is translating into the doctor's surgeries, where when we see someone who perhaps is middle-aged and they've got diabetes or high blood pressure or a risk factor for dementia, instead of just letting that slide and then they come back 20 years later and they've developed dementia, we're actively saying this is an opportunity for us to try and change the course, or at least push back the age of onset. And that really is new. You know, when I went to medical school, we were never taught that. And I have to say, I still think it's only since I moved from completely medical practice to now doing more research that I'm really learning that. So I think there is a bit of translation and education that still needs to go out to the healthcare providers of saying we can change trajectories, and that's a great story of hope. Because, of course, there are new drugs coming out that potentially can treat or stop or slow down Alzheimer's, but it's far better to prevent it than be in that position where you need to treat it.
Yeah, absolutely. And I think that personally, I don't know, everybody here, if I said, did you know that statistic before, that 50%, of people could change their outcomes now, was everyone aware of that figure? There we go. Like, I think there's a large amount of the population that don't actually realise that and put a lot more down to genetics and it'll be what it'll be. But I think that's a really encouraging message.
Yeah, and quite honestly, I didn't know that until I moved more into an academic position at the university. So I probably only learnt that myself 5 years ago. And I think there's that gap between what the researchers know and what the healthcare providers know. And that's kind of where, education and really trying to get that message out. And actually, there have been research studies done where they've asked GPs, they've asked neurologists, they've asked people on the street, do you think dementia is preventable? And it's something incredible, like about 5% say, yeah, maybe. But everyone else just thinks it's inevitable.
Yeah, that's quite fascinating, and I think definitely worthy of further conversation. Michelle, in relation to diversity, because you touched on this earlier, diversity and inclusion, also the challenge in having those people involved in research, from some diverse backgrounds. How would you say that in medical research it does benefit the outcomes, and it's very important to have this?
Yeah, absolutely. So. Before we've already hit on that, I'm enjoying hearing the overlap, the unexpected overlap in the work that we have in changing people's trajectories. Mine has been at an earlier stage in people's lives during pregnancy and birth. But the importance of diversity, especially in the work that I've been involved with around maternal health, is crucial because, again, coming up to that point, if we don't understand and can't address the needs, the unique needs of a diverse population, then we're missing opportunities to support people to be as healthy as they can. And coming back to those opportunities to nudge people, to nudge their trajectory, and you couldn't argue that it could be any more important to do that through pregnancy and in the early stages. We know that the first up to 5,000 days is hugely important. So any support that we can give to women and their families early in their journeys as parents and families can actually potentially alter those trajectories.
I feel like everyone's got so many questions, but we'll have to wait because I've got so many myself, but we'll work through the ones we're supposed to ask first. Now, I'm going to come specifically for the next couple of questions to you, Jane. I'd love you to explain the challenges in diagnosing young onset Parkinson's disease, in women that is, because that is an area that I suppose would be enormously challenging to actually put all the pieces of the jigsaw puzzle together and give that diagnosis.
Thank you. I do have a couple of slides here to go through this. I thought it might be nice just to break it up. Just struggling to advance the slides though at the moment. Just hang on.
We'll call tech support. Tech support will hear us. You see, I'll tell you a story. During the blue screen of death recently, does everybody remember that day? I definitely do. Oh, you've got them back. Okay, I'll tell you another time or after this.
I just wanted to put a little bit together on Parkinson's disease because you're going to be hearing lots about this through the media. There's a big push currently in Tasmania to really promote Parkinson's disease, and I'll tell you a little bit more about this. So I put this picture here purposely because I think this is our stereotype of a white older man. That's who we think in our mind, isn't it? Billy Connolly, Michael J. Fox. These are the famous people with Parkinson's. And in a way, you're not wrong. But I think the point we want to make is not everybody with Parkinson's fits this stereotype. I'm going to show you somebody else with Parkinson's. That's Michelle Calisaya, who is an academic at the university. She's also a physiotherapist, and she's living with young onset Parkinson's. That's really quite striking, isn't it? When you look at her, you think, gosh, she doesn't look like how I imagine someone to have Parkinson's. And for Michelle, she was on EBC radio last night, actually. She said it took almost 3 years to receive a diagnosis. And that's a bit our fault. I'm putting my hand on heart because I'm a doctor. We don't expect people like Michelle to have Parkinson's. This is somebody else with Parkinson's who developed it in pregnancy, actually. Rochelle is a nutrition expert in the UK. If you look at Rochelle Flanagan, she's now running a big women's Parkinson's project. Again, develops some symptoms in pregnancy. You don't expect pregnant women to develop Parkinson's, but this is happening right now. And there is an increased risk of Parkinson's that we don't fully understand. It's doubled in the last 2 decades. It's expected to double again in the next 2 decades. We don't know why that is. There's questions around, is it something in the environment like pesticides? But it's really important for Tasmania because we're at particular risk. The numbers are rocketing up and we're not sure why. This is somebody else with Parkinson's. This is actually my friend, Shaf, who's a dentist in the UK, and she developed it when she was 40. A dentist with a tremors, not ideal. So I hope that kind of makes you sit up and think, oh my gosh, I didn't expect this. Don't be afraid, don't think, oh my gosh, I'm going to get it, because actually going back to my point, there are things we can do to lower our risk. And I think it's good that we're talking about this with a mixed audience, because actually Parkinson's begins about 20 years before people develop a tremor or develop slowed gait. So there's a 20-year window when we can try and change the trajectory. And actually the work we're doing here in Tasmania is kind of one of the leading centres around the world, because we're being ambitious and we're saying, let's not wait till it's happened, let's try and prevent it. I just need to come out of this slide actually to play this video, so just bear with me. Following the instructions that Josh gave me. It's just a 2-minute video, but I think it really sums up a young onset Parkinson's disease and answers your question.
So when I was diagnosed, it was a period of grieving. A grieving for the person I thought I was going to be, a grieving for the future I thought I was going to have. Once I got over that and I accepted the diagnosis, I'm now carrying on and doing things which are above and beyond what I ever thought I could do. So when I was first given the diagnosis of Parkinson's disease, it did make me stop and take stock of everything in my life. And initially, I was like, what are the problems going to be? How am I going to overcome them? It was little things. I was writing a birthday card for my sons, and I remember afterwards sitting and crying and saying to my husband, am I not going to be able to write cards to my children in the future? Will my writing be so messy and tiny that I won't be able to write them? And I remember also being upset and saying to my husband, will my children be embarrassed, on their wedding days or their graduation days? But you get over it and you move forward. And when you move forward, you become stronger, and you realise that your children don't actually really care about who you look like, what you look like, as long as you're still there and as long as you're still strong. Take control of it, accept it for what it is, and then move forward with it. It makes you appreciate every single moment you are in and times it by 100. And that's something that I do keep reminding myself is, Shafak, you had this condition even before you knew you had this condition, and it didn't stop you from doing things then. So why should it stop you from doing things now? In fact, it should drive you on to be more than you were before. Parkinson's, it does take from your body, it changes your body, but my spirit, my being, it's still me, and I am stronger than I was before, and I hope to carry on being stronger than I was before.
She's amazing, isn't she? And I remember when she was diagnosed, I mean, she's absolutely right, she grieved. You know, that's not what you expect when you're 40. This is an open access paper you might like to read. You can see I wrote that with Shaf and Michelle, and we wrote it from a young onset Parkinson's perspective, with Shaf and Michelle having Parkinson's, and a neurologist's perspective, saying we're not trained how to spot it. We need to be spotting it because Shaf's carried on working. She's doing great as a dentist. She just needed the medicine, and for years she was suffering with the symptoms and they weren't recognised. I would love it if some people signed up. We're running a new Parkinson's project. If you put UTAS Parkinson's, you don't have to have Parkinson's. In fact, the more people without Parkinson's, the better the study, because then we can compare the differences. So please have a look at our website there. Sorry to make people cry.
I'm sorry, that was I was like, oh my god.
It is emotional though, isn't it? It's that human aspect, and you see somebody there you don't expect.
Grieving for the person I thought I was going to be, grieving.
Can I ask a question just quickly
Sure.
in relation to that? Is there any indication as to any lifestyle factors that contributed to those 3 cases of early onset Parkinson's, whether it be, I don't know, plastics in, you know, their life? I mean, I don't know, there must be so many possibilities.
I think that's a great question, and I think the short answer is we're not sure, and this is why we need more research. And Tassie's a great place to do this research because we've got a fairly static population, and we can start to look at what's in the water, what's in the air, who was exposed. You know, for example, a few people with Parkinson's said, I grew up near the apple orchards. Was it something that was sprayed on the apples or something on the fields? And that's why we need a large group of people that grew up in Tasmania to help us with this research, because we don't know. But Tassie's perfect for it because people tend to stay here. So if we want to look at a population and how they change over time, it's just wonderful to do that sort of research here. So I'll just skip through, there's just a couple more slides. And, you know, this is a very classical type of tremor that no one's going to miss, are they? You know, you don't need me as a neurologist to say they've got a tremor that looks like Parkinson's. And this finger tapping is showing that the tapping slows down. And these are the kind of things I look for as a doctor to make that diagnosis of Parkinson's. But keep in mind what I said before, that actually that pathology is building up in the brain 20 years before, and it's like an iceberg. So the top bit is where we've diagnosed it, but for 20 years things were changing. And it goes back to this point of, you know, inevitability, where people said, oh, you just developed Parkinson's. But what about if we could detect it 20 years earlier? Could we stop it? Could we do with Parkinson's what we've done with cancer, for example? I think we could, and I think we need to be ambitious, but not many people undertake this sort of research because it requires a population to do it. So what are the risk factors, or what are the early signs before people develop that tremor and slowness? And an easy way to remember it is the 3 S's. So people's sleep changes. Now don't panic, because if you're menopausal, your sleep will often change anyway. If you're depressed or anxious, your sleep will change. There's lots of things that change your sleep. But with Parkinson's, there's a particular sleep that pattern that occurs, which is called a REM sleep behaviour disorder. And this is when people, you know, when your eyes move rapidly, when you're dreaming, that rapid eye movement sleep. People with Parkinson's, they start to act out their dreams. So if they're dreaming of playing soccer, they'll actually kick or, you know, punch, and they start to be very active in their sleep. And we're actually running a study where we're trying to detect Tasmanians with this REM sleep behaviour disorder. We're running it through the Island Project, because if we can get those people, when pharma comes along and says, I've got a new drug to try early, we say, we've got the people 20 years before. Because people that have this REM sleep behaviour disorder are at 90% risk of developing Parkinson's. So the high risk group, and rather than just watch them change, let's try and change their trajectory. So we've been putting little actigraph watches on people to measure their sleep patterns. We've been using some computerised tests called TAS tests, which people do at home. They tap their fingers and the computer algorithms can measure the speed. And then we've also been posting out these, which are quite fun, where they scratch and you smell. and then you have to say which of these 4 scents it is, and there's sort of cut-offs where we know if you score below a certain number, again, you would be at higher risk of developing Parkinson's. So we're trying to get an at-risk population. And through the Island Project, that's all been done in people's homes. We've not brought anybody in, which is really nice because it means people that live rural, not near to Hobart, they can still take part in this research. And these are some of the fancy computer technologies that we've developed. This is just done through a webcam, and people just tap their fingers and the computer churns out some measures to say, look, that looks quite slow, which is far more accurate than us looking at somebody. I think this is my penultimate slide, just to say we're super lucky at the university. We've just got this $500,000 new movement analysis lab that's been funded through the university. And what this allows us to do, you can see there's some little cameras around the ceiling, and these can detect precisely all the different parts of the body. And we know that people that are really developing at very early stages of Parkinson's, as well as slowing down, there's just subtle little changes that you wouldn't see with the human eye. But we've got this technology. There's not many centres around the world that have this. So we're really sort of pushing at the limits of what we can do and being ambitious. You might have spotted a little bit of this. It's been on the press quite a lot that we've just started this new Parkinson's project. So say, just ask everybody to join. We're aiming for 5,000 Tasmanians to join, and it can all be done from home, those sorts of kits that I just showed you. This is back to Michelle that I showed you at the beginning. And we've just developed, Michelle's here again at Canberra, we've just developed a national alliance called the National Parkinson's Alliance, where we're trying to really increase the amount of funding. We managed to get $800,000 in the federal budget, and a large amount of that will be coming down back into Tasmania so we can do this sort of research.
Really quite fascinating. I'm sure that everybody agrees, and I wish there was 500 people in the room listening, but I'm very glad that you're all here. I've got a question just before we come back to you, Michelle. The parkinsons.utas.edu.au, that project that you're looking for people, versus the Island project, where people might be living out their dreams and hence have a greater propensity to Parkinson's. Are they two different projects?
They are two different, but you could join either of them. So the Dream one is actually in both. The Island project's been around for about 5 years.
Yeah.
It was very much about trying to prevent dementia, and similar sorts of things will be done in the Parkinson's project. So it doesn't really matter, but I would probably say if you're going to join one, no, I can't say that. Join them both.
Yeah.
They're all online.
And one final question. You talked about sleep. People who have sleep apnea, so may or may not use a CPAP machine, are there indications that lack of sleep can lead to dementia and Parkinson's as well?
So certainly sleep apnea does increase cognitive decline, and it's a treatable cause. So if people have sleep apnea and they use a CPAP machine, we see their cognition pick up. So it's really important to detect it and treat it.
Thank you, and we'll come back to everyone's questions soon. Now, Michelle, it's such a fascinating area, and we're getting great audio in both cases now coming through with the microphone, which is perfect. I want to talk about maternal obesity, and it's not about making people uncomfortable, but I think obesity in this day and age is easier to define. But is it a significant concern, and how does it affect sort of health in preconception, pregnancy, and post-pregnancy?
Yeah, absolutely. My slides that seem to have a mind of their own
Okay.
might help me talk through some of this. So what I'll be talking about in response to your question is some work that we did. We were funded, I led a project, we worked in collaboration with clinicians at the Royal, as I mentioned, around antenatal care. And that was funded. We were one of the major grant recipients for the Research Foundation a few years ago now. And that did initially was focused around maternal obesity, which we'll talk about in the next slide. But we spent a lot of time focused around actually what's the most important thing to do here. It's around supporting behaviour change. And working in maternity services, there are a number of behaviours that are really important in terms of the women's health. So smoking, substance abuse, there's a lot that is being dealt with in that service. So while I will address maternal obesity in a minute, what we ended up focusing a lot on was how could we support the clinicians around this important thing of helping people to change their behaviours. Because we know it's really hard. I mean, who here is perfect? Who here is doing everything that they should do? It's very hard to change habits, and I would hazard a guess that most of us here are possibly well supported and resourced to do that. And coming back to that question of diversity, as you said before, we know that there are a lot of people struggling, doing it tough, who don't have the same opportunities that we do. And it's still hard. So we know that there are benefits in terms of lowering the chances of getting long-term illnesses, such as what Jane has been discussing. We know that supporting behaviour change can boost our mental health and well-being. We feel better quality of life. Well, they're possessed. And the societal benefits as well too. But one of the challenges that we picked up on very early in our study with the maternity services team, and now I know that this is reflected across health professionals more broadly, is that health professionals often don't have training in techniques to encourage behaviour change techniques. It's just not something that they get taught, and it's not something they get as continuing education. And certainly not something that you can use in those time-limited, you might have 3-5 minutes to discuss an important health behaviour with someone, if you're lucky. So it could be, and especially in maternity services, often you're not seeing the same person throughout your pregnancy, so you might only have one opportunity in that whole pregnancy to have hopefully a meaningful conversation. So that was a long-winded way of coming almost onto maternal obesity. So I thought today what might be more useful to talk about is a little bit of a background quickly into the work that we did at the hospital. That's what sort of seeded some work which I've gotten really into, which is taking one of the things that we really found worked in that project, which was a particular health behaviour training from the UK, and we've now sort of broadened that out. So yes, it's initially started in sort of women's health, but now it's we're trying to take the world by storm with it. So coming back to your question, so some of the risks, I guess, associated with overweight and obesity, we're probably already familiar with them. We know it's a really tricky, often stigmatising thing to talk about. So I talk about this with sensitivity, but we know that there are more Tasmanians living with obesity than the rest of the country. We've got over 50% of women presenting living with obesity, overweight and obesity at the first visit. But in terms of coming into the service, so there are some complications with that. We know that there are people who can live with overweight and obesity and go on to have very normal, healthy pregnancies. So that's just a message to get out there. But there are heightened risks to do with some pregnancy complications listed here, some delivery complications, and there are some of those longer-term outcomes, adverse outcomes for babies and mothers, including for babies there can be links to later metabolic and cardiovascular disorders later in life. But that's really tricky, and it's not something that you really necessarily want to address while a woman is pregnant. So what you can do is look at weight gain in pregnancy, because there are independent risks associated with that as well. So even if you start at a normal weight, what's considered a normal weight, if you were to gain too much or too little in the course of your pregnancy, there can be risks associated with that too. So that's what we sort of started out to address, but as I said, we came to want to, as a team, felt more comfortable just talking about health behaviour change and how we can do that in a non-stigmatising way. Because, to be honest, you talk to the midwives and obstetricians, and sometimes the most pressing concern could be severe substance abuse, and that's what they need to really focus on. So I've gotten a little bit off track there. But in that project, one of the things that we identified clearly was there's a lack of training to have these conversations. There's a lack of appropriate patient resources, as we were talking about before. You've got women, often we know that Tasmanian women Tasmanians can have lower rates of education, lower health literacy rates, and this is reflected, we should be providing women with information that's accessible to them, and that's not necessarily the case. And also, one thing that in Tasmania we lack is options. So as clinicians, referral options. So not everything can be done in the room, and we know that in other parts of the country there are referral options. There might be an allied health professional, dietitians, those sorts of things that you can access to, even phone support like Get Healthy lines and things like that. But we don't have access to them. So just quickly, what we did in that project was we decided that we would try and use the opportunity to pilot how we could upskill clinicians to have those really opportunistic, brief conversations with people, because they can be what nudges you, as Jane was talking, in a direction, a healthier direction for people. So we were able to access this training, which was developed up in the UK. It is designed to be for any frontline worker, but it does work really well in a medical setting. It is not commercially available. It's kind of done for love, with good evidence. So no one's making money out of it. And it works off a train-the-trainer model. So I thought, perfect for Tasmania. We're under-resourced, and all we need is a free, nothing's free, but we need a free training that might work. So we tested it out with mostly midwives, and they absolutely loved it. And so what it is, it's about having those person-centred, they call it person-centred, but it's really about asking questions in a different way to get information, more information, ironically, in a different way, and empowering the women to decide what it is that they're wanting for themselves, what's working for them, what are the barriers, and coming up with their own plan. It's as simple as that.
I'm trying to figure out or imagine the sorts of questions that would be answered in this sort of healthy conversation skills training. Is the midwife, the clinician, the nurse, the person who might have been lucky enough to get the training, are they asking obvious questions about, say, substance abuse, or what is it that's forcing you to eat like this? That maybe is it financial? Do you not, have the background to understand the healthy cooking? What sort of questions would you ask to get outcomes?
Yeah, absolutely. So it's as simple as asking, reminding people to ask open-ended questions, but particular ones. So instead, and also in a way that could be less stigmatising. So if I was to say to you, why aren't you doing enough exercise?
And I'd feel defensive and say,
yeah,
go away, I'm not going to talk to you anymore.
That's right. But if you were to ask, what's important to you about exercise? What's getting in the way of you doing that? How can you be supported?
I'm tired, I've got 3 children, I've got no time, I've got a job, my husband isn't helping me.
That's really tough. What's one first step that you can take?
I will, I don't know, that's a good question. What will I do? I've got 3 children, a husband that won't help, a job and 2 things to do. I'll skip on the spot when the kids go to bed.
Yeah. How important is it to you to change you?
Well, maybe it might not be important though, because they might not see that that's just so many other things to do. Life is a grind.
That's right.
But I guess it starts the conversation.
It starts the conversation.
Yeah.
And as a health practitioner, I might have used 2 or 3 precious minutes of our consultation to tell you all about exercise and how you should do it, because coming from a good place, that's how we tend to want to convey our information.
Yeah.
And you're like, but actually, if you'd asked, I'm not that interested. Actually, I really want to talk about my smoking. So those sorts of things. So that's a very quick, you've been a very good... So it's as simple as that, but it's, listening more than, oh look, they're possessed again, I only have to point at them.
Yeah.
And
Okay, so it's an open-ended line of questioning that's helped people to get better outcomes.
That's right. And the point being that we tested it out, the clinicians loved it, and it was something that they could say, I can use this tomorrow. It's as simple to be able to do that, and it's open, it's just a different way of communicating with the people that they see. Family, friends, teenagers as well too, speaking from experience. Anyway, we've done another program of work to see how this works in different services and settings, and basically with a very small amount of money, an extra $10,000, we've now sort of done the trainer version of this, and it's being picked up and run across a number of services. The point being that as something as simple as a tool and a communication skill to have these supportive conversations with clients, with patients, that might be, something that can help them prevent illnesses such as what Jane is looking at down the track, is something that I've gotten a bit passionate about. And what we're seeing is that that's continued on at the Royal. So the project finished a couple of years ago. They're now running the training themselves. They've put it into their graduate nursing and midwifery programs. The midwives themselves are trained to deliver it. And that is something that I guess I'm quite proud of. But just demonstrating that there's many more facets to public health, service resources, adequate, accessible information, but this is something that we can do, some small thing that we can do for those opportunistic moments that we have. There's hundreds of them a day, isn't there? So.
Well, yeah, I think it's impressive with $10,000 that you managed to do that, get right around the state, and yeah, so you know, under-resourced in many ways, and I think everybody's probably been watching on the news or listening to radio about, you know, the lack of resources in the maternity unit at the Royal Hobart Hospital. Midwives saying they're just under so much pressure and don't have the resources they need. So yeah, it sounds as though you know, more money would be great, and more staff in the hospitals would also be a great help. Is that something at times that frustrates you, because you know how to fix things, yet there's not enough staff to sometimes have those conversations with patients?
Absolutely, absolutely. I mean, I can speak more anecdotally than from a research capacity, but I've built strong relationships with the team, and I know this to be the Royal, but also many other services, mental health services where I now work, struggling to staff services in a way that would be ideal. There's a national and global worker shortage, so there are lots of issues around attracting people and retaining our workers, and it doesn't help when you're in an already, you bring them here and then it's just stressed and stretched. And yeah, so ideally there'd be more time and resources to do all of this, and more people to allied health support and those sorts of things as well.
I'd be curious to know, I don't want it to seem like you're in school or in kindergarten, but is anyone happy to put their hand up if they work in health? Because yeah, okay, that's a lot of people here that you know, clearly have a passion for health. So yeah, thank you. Just out of curiosity more than anything. We did really touch on this, so we can answer it just briefly, Michelle. But the challenges young mothers face in Tasmania specifically, and how your research is contributing to better health outcomes. I mean, I feel like we did mostly touch on that, but if there's anything else you wanted to add.
Probably not, except that maybe one thing. We've touched on Tasmania doing better than it should in sort of being higher in its risk factors, and we know that for particularly young Tasmanian women, they've got the highest rates of smoking in pregnancy, for example, and they face additional challenges in terms of accessing pregnancy care, but also healthcare in general.
And why is that? Is that because of people in regional areas more so? Is it lower socioeconomic? What are the main contributing factors?
I would say it's a mix, and again I speak anecdotally and more from my experience looking at the way that the teen mums were supported at the Royal. It can be geographical, it can be, as you know, you hear stories of people not being able to make their appointments because it's raining and they can't get to the bus stop. And so they just miss their appointments because there's no other way to get in. You can talk about eating more nutritionally, but that's difficult if you're on someone's couch because you've got insecure housing. And they could be issues for anyone, but it's more prevalent, I would say, in a younger population.
Now, this might be getting way too controversial, so just pull me up here if it is, but is access to abortion for very young people also something that needs to, without you necessarily having to dive into that, should be, you know, factored into, you know, the difficulty, because if somebody can't manage a pregnancy, they didn't want the pregnancy, but they just didn't have the knowledge or the access. Do you think that's something that should just at least be considered in all of the equation? I'm
conscious of talking outside of my area of expertise, but I think speaking more broadly in terms of equitable access to whatever it is that people are wanting to have support with is hugely important. If there are limitations to abortion, if that's what is appropriate for the person and it's not equitable, that's an issue, I think.
Yeah, but all women's health indeed. Now, either of you can weigh into this one. What would you see as, you know, the next steps in your research? We'll go to you, Jane. You probably need a sip of water. That's a lot of talking. Sorry for all those questions. And so your next steps and how you sort of foresee these things impacting women's health in Tasmania. I mean, you've touched on the different projects, which sound amazing and interesting. I'm ready to sign up for one of them myself.
Oh, thank you. Yeah, I mean, I think those are the next steps, that we've moved from just primarily treating conditions to actually trying to prevent them. And I do think here in Tasmania, I've used the word ambitious. We are being purposely ambitious to try and prevent some very common conditions. And so I think that is the next step. I don't know if that's happening worldwide yet. There are drives towards that, but it's how do you implement that research? And in terms of particularly women, I think really it's doing those research projects, but specifically looking at how are women tracking, you know, does modifying this particular risk improve just for men or just for women? And it sounds so simple, but it's not been done very much until recently.
And how would you answer the same question, Michelle? So, you know, the next steps in your research and, you know, what you hope what your outcomes will be for women in Tasmania.
Yeah, absolutely. Well, I've already flagged that I've moved a little bit away from women's research specifically, but holding the relationships dear that I have with maternity services, and in that regard, we are looking to expand and consolidate. So there's training that I talked about. Again, a small aspect in the care that we can provide, but we are looking to consolidate that so that can be offered sustainably into the future, because I'm gratified that I've handed that on now. That's in the hands of the clinicians, but they want it to continue and they want it to be sustainable. So now we have to figure out how to make that happen. And I guess also have a strong interest in women's mental health as well too. So watch this space. I'll be doing more research on that.
Fantastic. Now we're going to be able to have a chance to take some of your questions. How are we going for time, John? Just so I try and keep us on track.
10 minutes.
Yeah, okay. I've got thousands of questions all the time because that's the job that I do, but I want your questions. So does anyone... Yes? Yeah. Fantastic.
Hi, I'm Catherine. I work within the mental health policy space, so within the Department of Health, but I also live with chronic illness. So I was diagnosed at 18 with an incredibly rare neuromuscular condition, so that sort of speaks to your work, Jane. And the difficulty that I think I've had over my own medical journey is that sort of sense for me that there's that reluctance from my neurology team to be able to provide resources. For instance, I remember having a very candid conversation with Michael Dreyer, who was my training clinician at the time, and said, you know, can I reach out to anyone within the community? And it was like, you have this incredibly rare neuromuscular condition, so there's like probably only 2 people in Tasmania with it. And, you know, I suppose the question that I have is there more being done in that kind of rare diseases space for people that do have really incredibly rare conditions that they're managing? And, you know, like I broke down in tears with your friend on the screen because I can totally relate. Yeah. And, yeah, just interested to know if there's more support for women, in particular young people that are getting these like rare conditions diagnosed at a very young age and going, my clinicians can't tell me because that's like conflict of interest and it's a privacy concern, but it's supports from the community for people that have rare diseases that need that kind of, you know, there's more supports now. Muscular dystrophy Tasmania is a newly established thing. I actually had I've got myasthenia gravis, so that was, you know, it's one of the top 10 rarest neuromuscular conditions that you can contract, and they weren't looking for it when I was diagnosed because they thought you're a 16-year-old woman that has all these symptoms that we're not going to diagnose you because it's just not what young females get, and that was the worst case I'd ever seen in Tasmania.
So you'd like to know if there's more support services?
I'd like to know if there's more being done in the rare diseases space.
In research and support? Yeah, thank you. It's a really interesting question. Thank you.
Yeah, that's really interesting. And thank you for sharing your story there. It's a very personal story. I think if you have a rare condition, be whatever that is, that's a very lonely place to be. Because I think it's a human nature that if somebody understands what you're going through, even if it's just one person, they can walk that path with you in a way that a doctor can't or a loved one can't, because no one understands that except someone having that condition. I think there's two things that are happening. I don't think these are specific to Tasmania as such, but I think from the grassroots up, people like yourself are starting to form their own groups and their own networks, and I think social media has been incredibly helpful for that. There are risks with that, because you end up having some people running Facebook groups that, you know, how good is that information? But I think that kind of buddy system is so helpful, you know. And I remember when I had my first baby and I didn't know anyone with a baby and everyone was at work and I was really lonely, and the midwife said to me, there's actually a lady around the corner who's just had a baby. It's the best thing ever, you know, we're still friends and so on. And I think at the end of the day, Tasmania's got a relatively small population, so if you have a rare condition, just, you know, the law of probability, there's only going to be a couple of other people in Tasmania with it, but using digital media, suddenly you can connect. And as you've mentioned, the Muscular Dystrophy Society, I think sort of top down, there are now more organisations for rare disorders. But I think we need to do more, you know, and I was running a Parkinson's clinic the other day and a man came in and he'd had Parkinson's for 20 years. It's not rare. I said, do you know anyone with Parkinson's? And he said, no. I was thinking, gosh, the man I just saw before, I just know you two would get on. But my hands felt tied because I was like, I don't know if I'm allowed to do that, but I just know you two would have a great coffee together or something. Yeah. So I think we do need to think about some kind of buddy system.
And someone to facilitate with permission from each individual person. So look, you've started a conversation that might lead to something really positive, where perhaps there, you know, could be some sort of, whether it be voluntary or paid, or a role that facilitates people going through issues like yours. So thank you very much for sharing, and hopefully that answered your question. Does anyone else have a question at the back?
Hello. This is a question for Jane, I think. Jane, you said that lots of people can change their trajectory. Do you mean to say that that's only once they might have the initial parts of the disease, or are you saying that if we all had 4 serves of oily fish a week, half of us could change that? Like, is it a true initial public health messaging, or is it once that disease has already started taking hold?
Great question, and I think the short answer is we're not sure, because this is quite new information that we can change our trajectory, you know, and I mean the last decade or so. Speaking for dementia, where I think there's a lot more evidence, there are now, if you look up dementia risk factors, Lancet Commission, there's now 14 named risk factors, and it'll give you the percentage risk you can reduce your risk of dementia if you adjust those. You know, and there are things like hypertension, diabetes and all those things, but it's actually also things about socialisation, coming to this sort of meeting or meeting someone over a coffee. You know, mixing with other people lowers your risk of dementia. Now we know that on a population level, of course some of us will carry genes that make our risk of dementia higher anyway, or we're female, that increases our risk of Alzheimer's. We can't change that, but we can try and change some of those other modifiable risk factors. As for Parkinson's, this is like hot off the press that we might be able to change our trajectory. It really is. I think, speaking in general terms, it's never too early to start, but I think particularly from 40 onwards, I'm in that group now, we should definitely be trying to look after our brain health. And if you can't remember all the risk factors, just think what's good for your heart, and having a good chat with our friends is going to be good for our brain. But actually, to go back to your first part of the question, we do know that people that develop in the earlier stages of these conditions, if they look after their brain health, it seems to push back the onset of more. So if you've got mild cognitive impairment and you really look after your brain health, it can push back the onset of full-blown dementia. So it's never too early, and it's kind of never too late either. But I don't claim to have all the answers. It's work in progress.
Does anybody else have a question they'd like to ask? Yeah.
Jane, I was just going to ask, is there much research being done on like short-term one-off events causing neuro disorders?
Oh, that's interesting.
Yeah. Like, I'm just very specific here, thinking about having an anaesthetic. You know, triggers that can maybe trigger something in people.
Yeah, that's a good question. And there is some, work done with mouse models of dementia, that if you give an anaesthetic to a mouse model of dementia, it appears to drop the abilities. Sometimes that comes back up. And then with humans, we've been concerned about that. If I have multiple anaesthetics, am I at risk? I don't think the evidence is there yet. And then I think, it's quite traumatic on your body to have an operation, so there's going to be a bit of a setback in terms of your thinking abilities, but normally that recovers. I think the area where there is some emerging evidence is actually around stress, and this is an area we're really interested in, that many people who develop Parkinson's will describe a period of quite severe stress in the months before, and that used to be like, well, you just remembered that, or, it's recall bias. But I think now there's more evidence that actually stress is causing inflammation, and inflammation's really important for dementia risk and Parkinson's. So I think we're still learning. And I think what we do need to do as doctors is listen to our patients, because one thing I do remember from medical school was listen to your patient and they'll tell you the diagnosis, but actually listen to your patient, they might be telling you what causes this condition. And people with lived experience of disorders have some really good ideas, and we need to be listening to those. And that's the lovely thing about being a doctor and a researcher. I can sit in a consult, I can listen to somebody and think, I wonder if I could just research that and just provide some evidence to back it up or not. And I feel really privileged that I can do that now. And I think that's the beauty really of being a doctor who's also a researcher.
I think it would be really lovely. Does anyone else have another question before we finish up? I don't want to cut anybody's questions out. Yep, go for it.
I'll go again. This one's for Michelle, and I don't even know what I'm trying to say here, but I think it's all those comorbidities that your pregnant patients are coming in with. At what point before that is there a moment where that public health messaging might have gotten through earlier before they were pregnant? Like in the antenatal pre-pregnancy stage, is there a moment?
Yeah, absolutely. I know that's the golden question. So as a person interested in preventive health, obviously it's from the moment you're born, you go to school, you go to secondary school, it's a message that should be reinforced. But being more targeted than that, trying to catch people in the preconception phase is really tricky, because for example, half the time people don't know they're about to get pregnant. So do we preemptively take our pre-pregnancy hormones on the off chance? And so there's work that colleagues have done, you're trying to catch people in the workplace, but then again that comes down to diversity and inclusion, because that's capturing a working population. What about the people who aren't working? How do we capture those? So that's when we're really relying heavily on public health messaging. And I'm a big believer in, going to school and having the Stephanie Alexander's kitchen garden program and just having it reinforced at every opportunity throughout our life course. So that's easy enough, isn't it?
Well, I think that we've all learnt so much today. It's been fantastic. I just thought just for, 90 seconds for the very end of this, I think we could take out of this that healthy living on so many different, different things we can do is a way to prevent early onset dementia, Parkinson's. It's good for our heart health, it's good for mothers, it's good for pregnancy outcomes for babies, possibly also good in cancer prevention. So if we had to just sit here and name those things, trying to keep where we can healthy with our eating, keep our weight to a healthy level, trying to, let's think, well, exercise as much as we can, some exercise to be better than we might be being. I'm not brilliant on that department, planning to get better. So exercise, good food, what are some of the other things we can name?
Smoking.
Yep, try to give up smoking if you are smoking.
Unfortunately, alcohol as well too, as far as that is.
Okay, yeah, so there we go. So making the list, okay.
My things are the social things. So mixing with your friends, going out to your, I go to a book group and I'm absolutely shattered before I go. I always come away and feel happier, but it's also really good for my brain. And there's good evidence that if you have wide social circles, that reduces your risk of dementia. And actually education, which is really relevant to tonight. So we've done a lot of work in Tasmania on older people going to university and that is also improving their cognition and reducing their risk of dementia. So you're doing all the right things coming tonight, learning.
Yeah, fantastic. And so there would our takeaways are connections, socialising, reducing alcohol, cutting back or cutting out altogether smoking, exercising, good diet, and where possible, keeping our brains going, and as you know, putting ourselves outside the comfort zone with a bit of education. And I think coming tonight, listening to talks like this, does all of that. So I want to thank everybody for joining us here this evening. A very special thank you to our guests here. The Royal Hobart Hospital Research Foundation, if anybody doesn't know this, has funded $11.5 million in research since 1997. If you know any philanthropists, anyone who want to donate a few $1 million, it's a very good cause. It directly benefits the health of our local community, and if you want to learn more about the foundation, if you're interested in supporting them, then you can speak to one of the team members tonight. And thank you to St Luke's for hosting us, and really hope we get back for another seminar in the not too distant future, because I think it's a great way to get the word out. Thank you.